Good evening and welcome to Supporting a Healthy Lifestyle, presented by Kansas Avenue Seventh day Adventist Church. We have an excellent program this evening, and I'm very proud to have someone I consider a friend to be going over this important topic, especially as it relates to minorities and African American men. Prostate health is a really big issue in our communities. A lot of the individuals in our community are diagnosed late and have some real high mortality rates. So this is going to be great information for all those who are going to be tuning in this afternoon. Let's start with a quick word of prayer. Our dear Heavenly Father, we thank you for this opportunity to share this important information with our church members and all those who are listening or viewing. We ask that this information will be taken to heart, and that we all can put this information to work to maintain a healthy lifestyle, so that we will have the energy and stamina and vitality to do the work that you'd have us to. These things we ask in your Son's name. Amen. So our guest speaker today is Dr. Leon Seard. He is a board certified urologist, and he started out at Oakwood University, where he was summa cum laude, which basically means he's the very, 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 very top of his class. He then went on to medical school at Loma Linda University and did his residency at University of Southern California. After finishing up at USC, he worked down in the Fountain Valley area here in Southern California, and was part of the Talbert Medical Group. He rose over the next 18 years to become the chairman of the urology department, the chairman of the entire department of surgery, and even the chief of the entire medical staff. He had an excellent career. He left there for a few years and went over to Tennessee, but he's back now here in Southern California at University of California, Irvine. More importantly than his academic career and his incredible professional medical career is the fact that he's just a good man. While this is not exactly on topic, I'm going to take a few seconds. For those of you out there who are watching who don't believe in mentors and what having a positive role model can mean, I can tell you that without Dr. Seard, people like Dr. Eaton, Dr. Carlton Sampson, despite having two parents, an older brother, a great family structure, I would not be where I am today. The whole concept of having or using a village to raise a child is so important. And I've always had an opportunity to look up to Dr. Seard, as he's done so many wonderful things. He's always willing to give of himself and time, his expertise. He's gone on mission trips and been involved in all kinds of international opportunities to help and serve others. He's a wonderful speaker. He preaches from time to time. He has and always will be a rock star in our denomination and someone who I consider a really good friend. So without any further delay, I present to you Dr. Leon Seard, who's going to talk with us today about the important topic of prostate and health. Dr. Seard?
Well, thank you, Dr. Finnison. I mean, that was really, whenever somebody introduces you, it's always kind of a feeling of humility and this kind of surprise too. I feel, even though you consider me a mentor, I kind of look up to you just as well. So it's really an honor to be here, and participating, helping Kansas Avenue, of course, is special. That was home during medical school. So even though that was many years ago, but it's amazing because I'm celebrating my 40th reunion from Oakwood, which means I came to Loma Linda 40 years ago in June. I'm good. I'm glad to be here. This is something I really enjoy doing. talking about prostate cancer, or especially to my community, to my church family, and especially the ethnic family part of the church as well. And so I'm really happy to be here, and hopefully we're going to get through this PowerPoint presentation and leave time for questions. Hopefully some of your questions will be answered in the process of the presentation, but if not, just you have the questions and we'll try to get to them and take care of those questions. So without any further ado, I'm going to try to pull up my screen, and let's see what we got. We got that. We got that. Uh-oh, it didn't give me my other. Can you see that? Okay, there we go. Okay, all right. All right, can you see that? All right, unfortunately, I can't hear anybody. Can you hear me? We got to figure out how this. Okay, I just want to make sure.
Dr. Seard, you're good to go.
Okay, good. All right, I'll pull it back up.
We just need to turn it into the presentation mode now.
Okay, all right. All right. All right, here we go. Your prostate and you. That's our topic, and what I'm hoping to do is cover the prostate cancer as well as non-cancer problems for the prostate. This being a church group, I always like to use the word as the foundation. The familiar text that we all know from Hosea 4:6, it says, "My people are destroyed for lack of knowledge." But we don't always include the next phrase that says, "because you have rejected knowledge." And basically, the admonition is saying that our lack of knowledge is our own fault for not having, and that when there is available to us. Often when I give this talk, I appeal to the woman with the issue of blood found in Mark 5, and round about verse 27, it says, when she had heard of Jesus. So in other words, when she got some information, when she got some knowledge, she then went forward to seek her health and correction of her disease. And so that's what we want to do this evening, is to provide some knowledge so that we will not be guilty of rejecting knowledge, and we will not be guilty of missing out on it. All right. So first thing I want to say is one of the things that we always find out, people will say, instead of prostate, prostrate. Put that R in there. Now, prostate is what we're talking about tonight, the organ in your body. Prostrate is how you bow before the Lord. So that, just remember, when you're talking about, we're talking about your prostate, not your prostrate. All right, just as a quick anatomy lesson, I don't know if you can see my cursor, but this is the side view of the male pelvic anatomy and genital anatomy. And so the prostate gland is this kind of small walnut-sized gland here, reproductive organ, and its purpose is to provide fluid and nourishment for sperm. And it grows in response to testosterone, and it normally grows in men as they get older. So you see here's the urinary bladder here. These are called the seminal vesicles, where the semen is stored between ejaculations. And then here's the testicle here, and the semen comes up in the vas deferens. Notice the prostate is right in front of the rectum, which makes an easy access in terms of us being able to examine it. And most of cancer happens in this area that we can feel with our finger through the rectum. So that's your quick anatomy lesson. Now, quickly, we're talking about diseases of the prostate. benign prostatic hypertrophy, which is just, oh, I call it old man's disease. It's a overgrowth of the prostate. Every man gets it. Some people get more than others, but as you get older, your prostate is going to get larger. Then there's inflammation of the prostate, or prostatitis. Anytime you see those four letters itis at the end of anything, that means an infection or inflammation of it, whether it's tonsillitis or appendicitis, it means infection or inflammation. So prostatitis refers to infection or inflammation of the prostate gland. And then there's prostate cancer, which is a big issue for men in this country, basically the number one cancer of men in this country. All right, so when we talk about prostatic disease, how do you know that something may be wrong with your prostate? What are the symptoms that you may experience that tell you something is wrong and you need to go see the physician? So just on the list, if you're looking at the left of the screen, there's nocturia, which is a fancy word saying you have to get up at night to go to the bathroom. And that's the number one reason men come to the office with prostate problems, is they say, I'm getting up 2 and 3 times a night, and I used to not do that. And I'm not liking this. A slow stream, we try to say you can't write your name in the snow anymore when you go to the bathroom, or you go to the ball game and you go out to go to the restroom, and the young guys are in there and they're in and out very quickly, and it's taking you a few extra seconds just to get things going, and the stream is not very strong. So it takes you hesitancy a few seconds to get started. And the slow stream and urgency just means you have to go right now. That urge to go comes on, and if you don't go, you might have an accident. Burning, just a feeling of burning fire when you urinate. And dribbling, this means typically at the end you're going and you think you're done, but then a little bit more dribbles out and you're not done. And then in completion, if you're feeling like your bladder is not empty, say, hey, I just went to the bathroom a few minutes ago. Why do I feel like I have to go again? So that's a feeling. All those symptoms typically have to do with the normal enlargement of the prostate. On the right side, there's some others that aren't specific for prostate cancer, but typically you're going to see in prostate cancer, as a rule, prostate cancer does not have symptoms. But if you do start to have significant symptoms, it may be that the cancer is advanced. And so you really don't want to wait till this stage. So hematuria, which is just our medical word for blood in the urine. Hemospermia, blood in the semen, which normally is nothing to be concerned about, but can be a manifestation of advanced prostate cancer. Urinary retention, or not being able to empty your bladder at all, not being able to go, you feel like you're in pain, you're discomfort, and you can't go. And if that lasts too long, that can lead to kidney failure because the urine is now backing up to the kidneys. Then if you've got the cancer and the cancer has already spread to the bones, you'll get pain in your bones. And then the area that's between the back of your scrotum or your sac and your anus is called the perineum. And you can have discomfort there with cancer, or more typically and most often, commonly, it just is the inflammation, the prostatitis. So how is it diagnosed? How is prostate disease diagnosed? Just like if we were talking to medical students, this is what you would know, is that you hear the history, or what you complain about, what your concerns are, what symptoms that you're having. Then we examine the patient and we look at your urine tests or urinalysis, and we do some blood work, the CBC or the complete blood count, or then looking at the lab tests that show how your body is functioning, how your kidneys are functioning, how your liver is functioning, how your bones may be functioning. And then we do studies that look at how you urinate, how well you urinate, how long it takes you, how strong the stream is, are you emptying completely? And then there'd be some x-rays that can be an ultrasound of your kidneys or your bladder or your prostate, or a CAT scan, a CT scan that looks more in depth inside the body. Cystoscopy is a procedure we do where we take a flexible telescope, for lack of a better term, and kind of look inside the bladder. We go through the penis, through the urethra into the bladder, and it gives us some idea of what abnormalities may be present in the bladder, or it gives us a good look at the prostate. Now, just looking at how do you treat it? What do we do about it? So if you see on the right is just a picture of a normal prostate, looking at from behind, which is the angle we would feel when we examine. And then you're looking at this middle one is how the urine is going. The top would be your bladder, it's coming through here. But as you get older, when your prostate grows, you see this tissue is growth and it squeezes out the tube. And so it's like trying to squeeze fluid through a balloon or a garden hose that you've pinched off. It's difficult to go through and the flow is not very good. So basically the two ways we treat benign prostate disease or the old man's disease is with medications. And the mainstay of medications are called alpha blockers, which is a fancy name, is that these medications allow the opening of the bladder to relax. It blocks that part of your bladder's tendency to tighten up and keep urine inside. So it helps it to relax it. And there are the most common ones that are being used now are Flomax or tamsulosin and uroxetrol, alfuzosin. Some of you may have used in the past Cardura or doxazosin. In the old days, it was Minipress or Prazosin. And then the most recent one is Rapaflo or Silodosin. So those are ones that are really designed to improve the flow of the urine as you try to expel it from your bladder. Then there's a second category called the 5-alpha reductase inhibitors. And what those are trying to do is prevent the prostate from growing. And the most common one is finasteride or Proscar, and others is dutasteride or Avodart. And what they do is actually kind of help the prostate to shrink. And often we give the two categories of medications, the alpha blockers and the 5-alpha reductase inhibitors, together because they are synergistic and they work well together. And typically together, they work better than either of them works alone, but many people are on one or the other. Then if medications don't work, we talk about procedures. The first one, the TURP, which stands for transurethral resection of the prostate, is the gold standard. That's kind of the classic way we take care of this. It's kind of the Roto-Rooter job, the reaming out the prostate, which we use when we're really eliminating this overgrowth of tissue. Now, typically that's done with a kind of a electrocurrent cautery, but it also can be done with a laser to accomplish the same effect. Then there's a microwave, which is kind of a heat treatment to kind of cause that tissue to kind of warm up and kind of dissipate away. Now, there's some newer treatments that are procedures, but aren't really surgery, so that they don't really require you to have anesthesia or general anesthesia or be in the operating room. And those are the UroLift. I probably should have gotten some pictures of them, but the UroLift is like it's placing some sutures within the prostate to stretch open the urethra tube where you pee, so you have a bigger opening so that the urine can go through. Then the Rezum is kind of a steam treatment where we inject steam into the prostate, and then it converts back to water, and the effect of that allows those cells to again to die off, and it shrinks the prostate as well. And then lastly, the aqua ablation is just kind of basically using water on the prostate and to get rid of it and shrink it that way. So those are the ways that we typically treat the benign or the non-cancerous prostate problems. And then we talk about the inflammation of the prostatitis. Typically that's done with antibiotics if it's really bad, but a lot of times we don't have to use antibiotics, or we use non-steroidal anti-inflammatory drugs like ibuprofen or naproxen, Aleve, those types of things. Sitz baths, we know being people of natural remedies, sitz bath is really aquatherapy or water hydrotherapy, where you just sit in the bathtub of warm water for 15 to 20 minutes and get some circulation down there, and it helps kind of get some of the evil humor, so to speak, out of that and get circulation going. It's very beneficial for people who are suffering with inflammation of the prostate. And then the same medications that we used I talked about this in the previous slide. Alpha blockers also help to assist in treating prostatitis. So here's a quote I use all the time. Anybody, my nurses hear it many times. The students or residents that rotate or spend time with me hear it. And it's a quote by the father of modern medicine, Sir William Osler. It's more important to know what patient has the disease than what disease the patient has. So in other words, too often we in medicine look at patients as statistics and as an object. We objectify them, and we look at this is, you have this disease and this is what we're supposed to do. Well, what the book says is supposed to happen, or what the research says is supposed to happen, and how you're supposed to be treated may not be appropriate for certain patients. And so it is our responsibility to figure, okay, this patient is not going to respond to this, or this patient doesn't want to do this. And so our responsibility is to know it's not so much what disease the patient has. It's important, better to know what patient has that disease. And for African Americans, we have a unique story, and we need a unique approach as well. And so that's something that I try to apply, and I think it's just pertinent and important for every physician to apply to every patient that they see. Now, we're getting into prostate cancer. You look at, there's some familiar faces here, and there are lots more that we can use, but these are all public figures and celebrities, from our own Dr. Ben Carson, to Harry Belafonte, to Minister Louis Farrakhan, Bishop Desmond Tutu, and the late Nelson Mandela, and the late Earl Woods. So these, when we talk about, this is something that's really prevalent. And unfortunately, too many times, nothing gets talked about or nothing gets addressed until celebrities experience it. And in medical things, that's always the case. But here are some people known to us that we can look and say, hey, they had it, and all of them, most of them, all of them were treated, and some of them didn't make it through. But that's certainly something to be reminded of, that, you know, this is a disease that doesn't have a respecter of persons. All right. But when we talk about prostate cancer, we need to think about cancer in general terms. And what is cancer? And my simple definition for cancer is just abnormal cells behaving abnormally. In other words, they're not staying where they're supposed to stay. They're growing in crazy ways. They're not functioning the way they're supposed to function. And they're going where they're not supposed to go. They're cells that aren't normal cells for that particular organ, whether it's the lung or the prostate or the colon or the breast or the kidney. They're not normal cells. And on top of not being normal, they're not behaving normal. And so that's the kind of a simplified definition of what cancer is. And this is some quick facts about prostate cancer. We look at it, it's estimated that this year, there will be almost 250,000 men with newly diagnosed prostate cancer, and about a little over 34,000 deaths from prostate cancer. And, you know, according to one of the advocacy groups, there's every 17 minutes, another man in this country dies from prostate cancer. The number of these deaths are increasing every year, and prostate cancer has for many years been the second leading cause of cancer death in men in the United States after lung cancer. All right, so here's some other things that, you know, made some controversy, but generally they are very important. So the death rates have been falling since 1990, and that's basically because of the research that we've had and done, and they're about the same rate as breast cancer. And one of the interesting things, and I don't have the slide, but I throw it in here, that in terms of comparison, breast cancer and prostate cancer are similar in terms of the number of people who get them and the number of people who die. But the amount of money spent in research is at least double for breast cancer than it is for prostate cancer. I'm always amazed, even in sports, you know, we look at those of us, you know, who still watch the NFL, we look and see October, they wear pink and they do all these things for breast cancer, which is a good thing because we need to support the women in our lives. But it's amazing to me that nothing is done in September. That's October for breast cancer, but nothing is done in September for prostate cancer in the NFL, which is I think is a tragedy, and that's something should be addressed. And that one time they tried to do it, and I think I've even tried to inquire, but maybe I'll try to do some more again, and more people do that. But it should be something that should happen. And interesting thing to know, we don't know that screening actually lowers death rates. But this is a little bit of a caveat here, because that's typically for the majority population. African American men are twice as likely to die from prostate cancer as white men. African American men have the highest incidence of prostate cancer in the world. So that's why this is an important topic, because more than any other men in the world, we get it. But if we get treated as we should, our survival is no different from then. As you see, the overall 5-year survival rate is over 90%. And a lot of that is because of the blood tests and technological and medical advances. All right, so we talk about who's going to get it. Obviously, the older you get, the more likely you are. And I tell patients all the time, once you get over 70, I would say, and going up in the 70s, if you can go from 20 to 30, I would say men in their 70s, statistically speaking, would probably have at least a 30% or more chance of having prostate cancer, just statistically speaking, without any of the risk factors. But the good thing is also, the older you get, especially if you don't have a diagnosis of prostate cancer, the less likely it is to be of some significance. And so we're most concerned about younger patients, but we still look into all men, certainly those who are less than 80 years old, and sometimes less than, or sometimes older than that, depending upon the situation. But again, as I said, we as African American men have the highest incidence of cancer in the world. And so that's a high risk population. There are two main high risk populations for prostate cancer: African American men and men who have a family history of prostate cancer. And that family history means a first degree relative, a father, a brother, or a son with prostate cancer diagnosed at a young age in their 60s or younger. And so even though you can extend that further, it's typically the first degree relatives, the siblings, the fathers, or the sons. All right, how do you reduce your risk of prostate cancer? We like to say that a heart healthy diet is a prostate healthy diet. So by doing all the things to keep your heart healthy, you're also going to keep your prostate healthy. And so a low fat diet, exercising, not smoking, foods that are high in the lycopenes, those red foods, tomatoes, grapefruit, watermelon, and the naturally soy food products may have a protective factor as well. So those are the simple, natural things that we do. But again, exercise and avoiding smoking and obesity is another risk factor for prostate cancer. So these are things that we can do to kind of help reduce the risk of prostate cancer. Now, when we talk about how we diagnose prostate cancer, quickly, and I'm going to try to move here quickly so I can spend the rest of the time with questions. But so the DRE, that's the digital rectal examination. That's the lubricated glove finger into the rectum to examine the prostate. And most people really hate that. I will get people to tell me, say, "Doc, I just don't like that part of it." And I said, I understand. But I usually, retort by saying women have been getting up in stirrups for decades to have their cervixes checked and everything, and we could at least do that. And I often, in church groups, I appeal to the story of Captain Naaman in 2 Kings 5, who his colleagues said, "Hey, if you've been asked to do some big thing, you would do it to be healed of your leprosy." And these are just simple things that we can do. So there's an examination, the blood test, the PSA, the prostate-specific antigen. That's the hallmark. That's the mainstay. That's the blood test, and that is normally produced. But if the value is too high, it makes us concerned about whether you have cancer or not. So that's going to require further investigation. The others are steps in diagnosing the TRUS. Well, that's the Transrectal ultrasound of the prostate, the biopsy. We use the ultrasound to help us to get the tissue, the CT or the MRI. The bone scan is looking to see if there's any spread of the cancer to the bones. And then there is the other blood tests, and then looking at what the DNA and the genes of that particular cancer or your family. But sometimes based on what we find out from that, we can tell if this is going to be a really bad cancer for you individually or not, compared to information that we already have. All right, so quickly moving, this is just a picture of how we diagnose it. On the left is just a picture of the probe that goes into the anus and allows us to look and get a ultrasound, a sound wave picture of the prostate. And this is how we use to then do the biopsy to get to that prostate. Nowadays, with the modern technology, this has been refined where we take the MRI, which you see on your far right, and combine it with the images of your ultrasound. And we call this a fusion. Artemis is just kind of the system that one of the systems. And but the principle is that we take the images from your MRI, which is very sensitive in terms of seeing abnormal areas, and then they rate it to see how likely it is to be cancerous. And then we got that, and we put those pictures on top of what we see in the ultrasound, so we can pinpoint and go directly to the abnormal area in the prostate that makes us concerned for cancer. And this is, again, just a kind of a schematic cartoon of what the body. You see all these little, this is where the needle is going. You see these various lesions here. We can go directly into these areas that make us worry about cancer being present. Now, when we talk about any kind of cancer, there are two little words, two 5-letter words that we almost always must be concerned about. The first one is grade, and the other one is stage. Grade refers to how aggressive the cancer is, how bad is the cancer, and we look at it with an organization or a measuring system called the Gleason score. And what happens is that the pathologist will look at the cells and say, hey, how bad do they look, from a number of 1 to 5, 5 being terrible. And then they look at the second biggest population and do the same thing, and they add those two numbers together. Most men in this country are either a 3 + 3 = 6 or 3 + 4 = 7. Obviously, the higher you are, the worse you are. So if you have a Gleason score of 7, 8, 9, 10, that's significant disease. Stage has to do, well, how much is there? And this is just showing local involvement. So here in this stage, you can't see the cancer or can't feel it. Here you can feel it. Here it's outside of the immediate confines of the prostate. Here it's really outside of it. And then if it's gone to the lymph nodes or to the bones or to the liver or the brain or the lungs, that makes it a higher stage. Then how do we treat it? So we're getting down to the end, but I'm going to quickly go through this. There's surgery. The radical prostatectomy, I like to say, is removing the cancer. Radiation is killing the cancer. Cryotherapy is also killing, but by freezing it. Hormonal therapy, I like to say, is starving the cancer by removing the hormonal stimulation for the cancer. And then chemotherapy is another means of killing the cancer. This is a picture of surgery, removing the prostate. This is in the old days. And here's the prostate here after it's been removed, and this is the incision here. This is done very rarely now because of modern technology. Now it's done with a robot. And here's a picture of the robot. Instead of the big incision going from the belly button down, you have all these little tiny holes with the robot arms attached to it to do the surgery. And what happens, the surgeon, instead of being at the table, as you saw in that early picture, the surgeon just sits here at this console and basically plays video games. He has an assistant actually with the patient, and the robot going into the patient. And that's how you do the surgery, by sitting here at this console in the corner. And that's the way in most cases, and we can see, the surgeon sees this picture up here inside, and the assistant can see the same thing others in the operating room. But the robotic prostatectomy is the way most of this operation is done today. Then there's radiation. There's radiation that comes from the outside of the body and goes in, and this is a machine showing a how that's done. A machine, the patient lays on there, and the machine sends radiation to the prostate and around to take care to kill the cancer. It also can be given, we call brachytherapy or seed implants. On the left, you see these tiny little seeds there, and then they use these needles to go, and here it is, you see them in the prostate, and they're placed. And when we do brachytherapy, you put many seeds in there. But that's another way, and that instead of having the radiation kind of going to a whole field, it's confined to the prostate, and that's just another way of treating it. This is cryotherapy, or freezing the prostate. So you got basically some ice balls in the area where the cancer is to kind of freeze that and destroy the cancer that way. That's not done very often as a primary means of treating the cancer. Often this is done in people who have failing of radiation. They use that. So that's not something that's done very often today. And here is HIFU, or high intensity focused ultrasound, which is probably the newest modality of treatment, where basically the probe goes in and sends sound waves to the prostate to treat it another way. And typically that's trying to treat right where the cancer is in the prostate, as opposed to the whole prostate. And then lastly, this chemotherapy, once the prostate cancer has gotten really advanced and all those other options are either exhausted or aren't available, or it's too far advanced to get it. And we don't want to get to that point, but at least 10 years ago or so, our options for chemotherapy for prostate cancer were very limited. That's not the case now. So it's really made significant strides in even prostate cancer with chemotherapy for prostate cancer. Lastly, I always appeal to the great Dr. King, who says of all the forms of inequality, injustice in health is the most shocking and the most inhuman. And even in this pandemic time, we know that, again, we as African Americans are adversely affected more so than the other majority population within this country. And this is something that we are aware of, and we should do all we can to lessen the effect of the system upon us. And so my goal is, by giving this type of information, can help give you the impotence to go and make sure that you're not a victim of the inequality in healthcare that is so prevalent today. So lastly, hopefully we've gotten some information, education, inspiration, and transformation, so that we can go from illness to health. Thank you very much, and that's it.
Excellent talk, Dr. Seard. And we have a few questions I want to get to. I know our time is short. As an Adventist community, we've been taught some of the importance of health and being a vegetarian, so to speak, and vegan and all those types of things. And a lot of that information has started to really gain some popularity these days among some of our primetime athletes and those types of things. So the question becomes, all the vitamins, the supplements you see on TV, are there things that we can take that can add to prostate health, or is it mostly just marketing that we're seeing on the television?
Excellent question. I would say for the most part, it's marketing. There are things like saw palmetto, zinc. There are other natural things that we can take to help, but by and large, the data does not really show how much you need, where they really work. And the one thing to remember about anything you see over the counter, even in the the GNCs and stuff, and certainly off the internet, is these medicational supplements are not regulated. And so that, beyond the fact that the data may not be there to say if they really work, and if they work, how much you need, and what they are not required to. You get a bottle and says, okay, they don't have to say that what they say is in there is actually in there in the proportions that are in there. So you don't really know. And so that's this is something to, and then the other thing is that a lot of times to the extent that some of those things work, they work because they undisclosed have some type of pharmaceutical that we use normally to treat these various conditions in that preparation. And it's enough. And I remember when I was in Tennessee that we helped shut down one of these men clinics for that very purpose. They were offering stuff that wasn't proven and wasn't really doing what it was supposed to be doing. And so that's just something to remember across the board. That being said, obviously being healthy naturally is going to be to your benefit. But we often forget that we can't expect sudden change of lifestyle over a year or so to totally reverse 40, 50 years of lack of caring adequately for our bodies.
One of the other questions that came up was, why is it that, as a general rule, African Americans are diagnosed late and have just not done as well? Is it primarily because we as a group don't tend to have access to care? We don't see the physician. We're afraid of the rectal exam. Or are we afraid of the potential complications of surgery if we do find out that we actually have something? And for those who are watching, again, we may touch on a few sensitive subjects, but obviously potential complications of surgery include erectile dysfunction and incontinence and those types of things. So if you had to kind of put your finger on, why is it that we really have done so poorly over the last, few decades, honestly, a couple centuries probably, in dealing with this issue?
I think all the things that you mentioned, another excellent question, all the things you mentioned can be blamed. Probably the one thing I think, if I had to put my finger, is just lack of information. So even just using for current events now, there's so much talk about Black people not wanting to get the COVID vaccine. Well, it's less about our not wanting to get the vaccine as it is about our access to the vaccine. And so, we there is a health disparity in this country, has been there for decades and continues. And so we're underinsured. We don't have access to fresh produce in the hood like other people do. We don't have access to the same pharmacies. So all those things take into play. And then, we don't know exactly why we are affected more in terms of disease is concerned, because even in Africa, sub-Saharan Africa tends to be a higher rate than white Africans. But we think it has partially to do with certainly genes, and then with the maternal testosterone. When our Black mothers are pregnant, they have typically a higher circulating amount of testosterone, which is the hormone, the male hormone that also stimulates the prostate. And so we think that may have something to do with it. Interesting enough, that same reason is why testicle cancer is very rare in us. For the same reason, because testicle cancer, you have a higher risk of it if the testicle's undescended, and the male hormone helps that testicle to descend. So we very rarely hear of testicle cancer in African Americans. It's just one of those things. It's sometimes what's good may be bad. Just like in Africa, the sickle cell was protective against malaria, and so when we got transplanted here, the sickle cell became a death threat to us.
A couple other questions have come through about treatments, and again, like what are the prognosis if you go through a prostatectomy, open or robotic? And I think we should probably discuss some of the potential complications related to treatment, because I do think that sometimes that can be a determinant for why some of the men in general are hesitant to address this issue.
Yeah, you're exactly right. I mean, typically the things we worry about, as you said, erectile dysfunction, incontinence, scar tissue. Those are the three long-term issues we have to deal with surgery. Surgery is the best treatment in terms of a long-term cancer-free survival. So if you're 65 now, your best chance to get to 75 and not have prostate cancer is to have surgery. Doesn't mean you're going to live that long. Neither does it mean that you will get there and not have cancer. Your best odds of getting there that way. With radiation, you have it's not surgery, so you don't have the surgical risk. You still have a risk potentially of erectile dysfunction and scarring, and then you have the risks of the damage that radiation is a permanent treatment. So it can affect your bladder, it can affect your rectum, it can cause scarring. So there are some disadvantages to using radiation, even though you are avoiding major surgery. And so the way the surgery has really evolved, and like I said, almost probably 90% of prostatectomies, radical prostatectomies, are done with the robot. And all of the complications that we knew from the classical open way, whether it's impotence or incontinence, are less with the robot. And there is typically that's blood loss. The catheter that has to be in place afterwards is in for a short amount of time. You're in the hospital a short amount of time. All those are benefits. The only place where there's really no difference is that in terms of the outlook for your cancer, the robot does not really give you any benefit over just the traditional manner. But again, most places are only doing it with the robot.
And again, speaking about cancer, is prostate cancer, I mean, is it curable? Is it treatable? I know it's obviously going to be better if it's caught early, but let's say you happen to have metastatic disease. I mean, what are your treatment options at that point?
So if you have metastatic disease or you spread outside of the organ of origin, your prostate, yeah, there is hormonal therapy, which is a systemic therapy. It kind of starts with cancer, and then there's chemotherapy. We don't want to get to that point, because obviously it's like any other cancer. Once you get to the point of this all over your body, the cancer takes over the natural functions, and that's kind of leads to your death. Years ago, the task force for the public health system said we shouldn't screen anymore, stop doing the PSAs, and we saw a increase in late stage or more advanced cancer as a result of that. And that was really irresponsible science, because they didn't, they tried to say that don't do A because E is inevitable, which is not the case. And then they said nothing about the high risk groups like our community. And they kind of revised that, but the take home point really should have been, hey, this disease is something you should talk over with your physician. Say, hey, this is something we should explore. Maybe we just get a baseline one. If it looks good, we can kind of follow it if you don't have any increased risk and if you don't have any symptoms.
Going back to why some people don't want to come see a nice young man like yourself is the rectal exam. I know you talked about potentially that some of that is changing, and that science is allowing us maybe to use more lab tests. I mean, could you elaborate on whether or not the rectal exam is still an important part of the diagnosis of prostate cancer versus benign prostatic hypertrophy?
Yeah. So yes, it's still a part of the process of diagnosing it, but it's not as if so. The blood test is more sensitive. However, you can have a normal blood test and still have prostate cancer. You can obviously, more often than not, you can have a normal examination with an elevated PSA, so we still do it. I typically nowadays mostly use it for if someone has an elevated PSA and they're relatively young, or I'm not expecting it to be the case, and I'll examine it and say, okay, hey, before I go down this track of getting to a biopsy, let's see if there's something abnormal there. If there's nothing abnormal there, then I may say, okay, we can maybe go a little bit slower slower in this, but it's still a part of it. It's just because the blood test is more sensitive and more reliable, we're kind of moving away from it. However, you did mention rectal cancer. The digital examination can help with that. But as far as prostate cancer is concerned, it's less of a, you're not doing it much. A lot of people from old school still continue to do it.
The questions still keep coming. So here's a question. Someone asked, how do you qualify for REZUM, REZUM? And I don't actually know what that is, so that I would throw it out to you.
So that's Rezum. That's one of the minimally invasive treatments for benign disease, enlarged prostate, when you're having trouble urinating. It's done in the office and only takes about 15 minutes to do. And basically, we're injecting steam into the prostate. And basically, it's an issue of what your insurance will cover. We're doing it more and more now. People say, "Hey, I'm tired of taking medications," and there's an argument to say having a procedure is better than medication, because the cost of medication for years and years can be more than the cost of doing a procedure once and for all, and you're over and done with it. So it's really an issue of, if you think that you need to have something done, or you're tired of taking medications, speak with your doctor about Rezum or UroLift, or however you want to consider being treated, and then also check with the insurance. But I think the insurances are, these most typical insurances are covered, but that's always the answer. It varies across payer systems.
Oh, one other question that just came in was regarding Viagra and potential use for individuals who have had some erectile dysfunction after a procedure. Is that something that they would need to get from you as a urologist? They typically see their primary care physician. What are the doses for it typically?
Mm-hmm. Usually Viagra, especially after, say, a prostatectomy or radiation, is going to be given by the urologist. There are three main ones that use Viagra or sildenafil, Levitra, vardenafil, and Cialis is tadalafil. Often after surgery, we will put patients on a low dose of that immediately, so that the pump is being primed even while recovering. So in the old days, if you had your prostate removed for cancer, you would want to be impotent. Now we can do what we call a nerve sparing procedure, which means we relieve the nerves responsible for erection, leave them in the body, and we can remove the prostate and kind of lift it away from that. And when those are done, you can pretty much say you can be able to still function normally, sometimes without any medication. Typically, we use 100 milligrams for Viagra. Cialis can use 20 milligrams. The biggest thing is that for whatever reason, the insurances generally don't cover it now. But if you want to use it, they're very expensive for something now. But the easiest way to kind of circumvent that is, one, Costco typically has a much cheaper rate, but also if you have your physician give you a large dose, like 90 Viagra pills, 100 milligrams, and then go shop on GoodRx, you can get them for basically pennies on the dollar.
Okay, that's good information that things can move forward, and kind of doubling back to healthcare disparities. This obviously can cross all specialties of medicine, and I guess I just was going to give you an opportunity to encourage our folks, because I have felt in some of the conversations I've had with my own patients that healthcare has been an issue in this country for sure. But sometimes when the healthcare is provided or recommended, we as a group are just a little more hesitant. I know you mentioned a few seconds ago about the COVID-19 vaccine, And I'm just trying to get across to people that they need to be evaluated and take the recommendations of their clinicians a little more serious so that they can be diagnosed earlier and have better outcomes.
Yeah. I just put the earplugs in. Hopefully, it will get rid of some of the interference. But yeah, you're exactly right. I mean, again, information, and don't be afraid. We are often too afraid to go get evaluated because, as you alluded to earlier, we're scared of the outcome. I don't want to. Some minutes, okay, if I'm going to have loss of this particular function, I'm not doing it. And I usually appeal to the point to say, okay, we're talking about our families, uh, our kids, our parents, our siblings, our spouses. We are important to them and they're important to us, and we should do all that we can to make it so that we are around as long as possible. And I also say that knowing that we're the victim of the social determinants of disease and the disparities and all that kind of stuff, I say, if you know a system is already stacked against you, it only makes sense to do all that you can to not expose yourself to that system. So it just said, let's do all that we can, getting your checkup and say, okay, you're going to, take your car in to get, tune up and checked up and all that kind of stuff. Our bodies should be the same way.
One of the last questions, we're almost done. We're going to be wrapping up here soon. How do you get qualified for focal laser treatments, and is it equal to a radical prostatectomy?
How you get qualified is, again, a insurance thing, because especially like the HIFU, that's kind of, it's not experimental. It has been approved in this country, but it's relatively new, only been out for several years now. And so you have to see what your insurance, and you have to go typically to a center has some expertise in it. The laser, same thing. Typically, a laser is going to be used for the benign disease, but it's a matter of what your insurance covers. But basically, those treatments aren't as good as surgery or radiation. I personally am not a fan of radiation, even though I know that it's a good treatment. I'm not a fan, primarily because the side effects of it are permanent, and surgery has a better long-term outcome of it. And typically, if there are ways for us to manage the complications that we get, and they're generally not as bad. And the effect of radiation is that it kills cancer cells, yes, but it kills normal cells as well. And that can affect you anytime after the fact. You can go 10 years after your radiation to find all of a sudden you start having bleeding and pain and issues. And so, I think, basically getting back to the rich coach, we want to do everything we can to make it so we don't have to go through these things.
During COVID, how's your practice been affected? Are you having to see more people through the internet, telemedicine? Do you see it as a trend that's going to continue with healthcare being the way that it's transitioning?
I absolutely do believe that telemedicine is here to stay. Even if doctors want to go back to it, they probably don't, but patients are going to ask for it. Patients are going to say, hey, during the pandemic, you saw me while I sat in my living room, my bedroom. Why can't you do that now? Especially where we're just talking about what's going on. So I think it's here to stay. On some level, it can help doctors do a whole lot and see a whole lot more if they don't have to be physically in front of the patient to touch them. And so theoretically, I could say, if I was going to see 30 patients, 25, 30 patients in the office, I could see, if I wanted to, another 5 or 10, either before the office opens or shortly after the office closes. And I can still, charge for those through the insurances. And so I think it's here to stay. We have not really been affected too much in terms of volume. Initially, when California shut down, yes, but right now, certainly everybody in my practice, for the most part, is seeing
the same number of patients they were seeing before the pandemic, but they are seeing more electronically. I'm probably seeing a third of my daily patient load is electronic.
Okay. I said that was the last question. I'm going to get one more in here. I know we need to quit. Since old man's disease, benign prostatic hypertrophy, is something we can more or less all expect to happen, the question is, once you have an enlarged prostate, let's say you're relatively young, 45, 50 to 60 or somewhere in that range, can the size be reduced by treatments, medications, diet, etc.?
Yes. So obviously the medication, the finasteride, that category actually shrinks the prostate. So that can be doing. There's another procedure what we call prostatic artery embolization for people who really, especially if they have really big glands. The radiologist can kind of embolize or block the blood flow, which causes those to shrink. But once you got to a certain, if it's not from inflammation, from prostatitis, and that's treated, I can bring it back down. But those medications, and again, just a low-fat diet and the heart-healthy diet is going to be basically the thing that's going to be beneficial. And just because your prostate is big does not necessarily mean that it has to be treated. But if you have symptoms, you want to get it evaluated, because if you're not having a kidney failure or bleeding or infections, or you just can't pee, then it becomes totally a lifestyle issue. And you say, hey, I can live with this, so be it.
Well, thank you very, very much, Dr. Seard. This was an excellent topic, an important topic. And to all the individuals who are watching, I hope we got a chance to answer all of your questions. Thank you for participating. And spread this information to all the ones that you love, especially from the African-American community and all minorities. Prostate health for men is an important issue. And we thank you for watching. Good night.